Good afternoon, and welcome to today's Fireside Chat titled Managing Healthcare in the Era of COVID-19, a Health Plan's Perspective. My name is Kathleen Lavelle, and I will be your MC for today's event. Our program will be 60 minutes in length. The first portion of the program is a conversation between our facilitator and our guest speaker, followed by a question and answer session. Note that an on-demand version of this program will be available approximately one day after the completion of the event and can be accessed using the same login link that you used for the live program. Before we get started, we have a few housekeeping details. To ensure that you can see all the content for the event, please maximize your event window and be sure to adjust your computer volume settings and/or PC speakers for optimal sound quality. Second, you will find a resources list for today's webinar in the lower left of your screen. Here we have listed the webinar slide deck for you to interact with. Next, at the bottom of your console, there are multiple widgets you can use. To submit a question, click on the Q&A widget. It may be open already and appear on the left side of your screen. You may submit questions at any time during the presentation. However, please note that it is likely that your questions will not be answered until the Q&A portion of the program. Finally, should you experience any technical difficulties during today's program and need assistance, please click on the Help widget, which has a question mark icon and covers common technical issues. Today's program is sponsored by CAQH. The ongoing need to reduce healthcare costs, especially administrative expenses, while concurrently increasing information accuracy, is at the heart of CAQH activities. In concert with a wide range of healthcare stakeholders, CAQH develops and implements shared industry-wide initiatives to eliminate long-term business inefficiencies, producing meaningful, concrete benefits for healthcare providers, health plans, and patients. CAQH initiatives are fundamentally changing the direction of healthcare, redefining how the industry does business today and in the future. CAQH is a nonprofit alliance of health plans and related associations working together to achieve the shared goal of streamlining the business of healthcare. BlueCross BlueShield Minnesota is home to the first Blue plan in the nation. The name Blue Cross came from this very advertisement seen here. Today, BlueCross BlueShield Minnesota remains the largest plan in the state with nearly 3 million members. BlueCross BlueShield Minnesota is statewide, both in the Twin Cities and Greater Minnesota. BlueCross BlueShield Minnesota is a proud Minnesota company with a local workforce of more than 3,500 associates. The network includes 100% of all hospitals in the state and 98% of the doctors, providing choice and security across every market segment. Individual purchasers, small and mid-sized employers, large and national employers, and federal, state, and local governments. At this time, it is my pleasure to introduce our speakers for the Fireside Chat today. Our guest today is Dr. Craig E. Samitt, CEO and President of BlueCross BlueShield Minnesota. Dr. Samitt serves as President and Chief Executive Officer of BlueCross BlueShield Minnesota and its parent company, Stella. Our facilitator for today's Fireside Chat is Soren Davis, Senior Vice President, Industry Relations, CAQH. With more than 40 years of experience in health insurance, healthcare management, benefits administration, sales, and marketing, Soren has served the healthcare industry from many perspectives. With that, I will hand it off to Soren.
Thank you. And thank you, Dr. Samitt, for joining in this Fireside Chat. To get us started, I'd like to ask you a top-of-mind question given today's environment. What have been the top challenges for your health plan amidst COVID-19 pandemic? And how long do you think these challenges will continue into the future?
Thanks very much, Soren, and good afternoon or good morning, everyone. It's good to be with you. The first thing that I would say, Soren, is unfortunately it's been an unprecedented and heartbreaking time, I think, for all of us But in Minnesota in particular, we've sort of been an epicenter of dueling pandemics. And so the challenges that you're asking about are altogether even greater as we struggle with both a clinical pandemic and a social pandemic, but very much appreciate the question. I would say that the challenges fall into several dimensions for us. The first challenge is obviously keeping our associates safe. And hold on a second. We've got some backup slides, but I don't think we need to use any of the slides yet. So I'm going to go back here. Thank you. So the challenges that we've got fall into several dimensions. The first is keeping our associates safe, as I'm sure is the case for many organizations. You know, we've been around for 80 some odd years, but the last pandemic was more than 100 years ago or so. And so this is truly unprecedented for us. And while we felt that we were well prepared, and in fact, we began to worry about a broader impact of the pandemic in February, no one really prepares you for sort of moving from a very live face-to-face organization to one that's virtual. And so we went home quickly, and actually as of March 13th, all of our associates were at home, and so we're now 98% virtual. We have been since mid-March, and we'll likely continue to do so until at least after Labor Day. And so for us, it's how do we keep our people safe, how do we keep them healthy, and how do we keep them sane? Because working from home isn't all that we had expected it would be. And so that's been challenge number one. Challenge number two for us is obviously keeping our members, patients, healthy, and assuring that they have access to all the care and services that they need in the pandemic. We've been very worried about either the clinical or the financial constraints or challenges for patients and what role that we can play to really help address them. And I would also point out that the challenge that we worry about are people who don't have COVID that feel scared about coming into the additional care delivery system, and we've all seen the same statistics about the underutilization of services that we would expect to see at this time. How do we assure that patients get access to the care they need in a world of social distancing when folks frankly don't want to use the system as it existed before? And then I'd say the last challenge for us is how do we as a health plan play a role in this environment when we may be differentially affected than others? So the environment that we find ourselves in is a bit different than the provider community. In fact, we don't struggle with the peaks and valleys. You know, it's in essence the role of an insurer. The insurer is here when costs are very high and when things are rough, and we're here when costs are low or utilization is low, so that we can actually use the benefits from good times to kind of pay for the bad times. And so I think the other challenge for us is to understand what role that we have to play. How long will these challenges continue? I think these challenges, I don't think we really know the answer to that in terms of when we will come back, but I suspect we're going to have a hangover of both of our pandemics for quite some time. It's unclear when we will all come back to work and whether we will come back to work to the same degree we did before. We envision that providers may continue to struggle. Folks that have been hesitant to come into the care delivery system in the midst of the pandemic may continue to have concerns out into the future. And in fact, care delivery as we know it may change quite significantly and quite going into the future. And you know, in terms of a pandemic related to the heartbreaking events of the last 2 weeks and the racism and the inequities and the injustice that we've seen, these have been going on for centuries, and so we would be short-sighted to think that the fix is quick, but the fix is necessary. And so this will be with us. There's an opportunity here for us to address this, frankly, in an intertwined way and consistent with the health pandemic.
Thank you. So following that train of thought, if we can maybe get into some specifics, like the type of actions that your organization is actually taking to address this impact, both on your members, your providers, and your community at large. And do you see some of these actions as being temporary until we get to the end of the pandemic, whenever that is? Or will many of these or some of them persist beyond the crisis itself?
Yeah, another good question. Well, let me start with our members, patients. As I mentioned, we wanted to assure that our members had access to high quality, affordable, and consistent care even in the midst of the pandemic. And so one of the very first things that we did, worrying about cost in particular, was waiving cost sharing for testing and for treatment. And one of the first organizations, certainly in our market, but also around the country, that really made that step to say this is not a time that patients should have to worry about being able to afford the care that they needed. So cost was one of the first areas of focus. Telehealth was another. We wanted to, if our facilities were closed, either for elective or even urgent related services, we wanted to make sure that there was an alternative modality for patients to receive care. Telehealth immediately, and opening up telehealth meant sort of immediate, with no out-of-pocket cost exposure to telehealth alternatives. Frankly, whether it was a national telehealth provider, and the one that we predominantly work with is Doctor on Demand, or local, which in many respects is a preference for purposes of continuity, could the physicians in our market, do they have the technical capabilities to be able to do visits? We wanted to make sure that that was the case so that patients could immediately convert at least a portion of their care to telehealth access. We also have expanded our outreach to members. This is a very isolating time where we wanted to make sure that folks had a voice to listen to and a person to answer questions. And even in some of our outreach to our members, especially our senior members, whether we could help either connect them with social service organizations or even assure that they had ample access to food or other supports. And in some instances, because we have a care delivery division as well, we were providing care in the home to those who didn't know what to do, and telehealth was not an alternative. And so we also pivoted to provide support there. In terms of provider, oh, go ahead, I'm sorry.
No. I heard you paused, so no, I don't.
Okay, great. In terms of providers, the focus there started on making sure that providers had what they needed in the midst of the crisis, which at the very beginning was access to PPE. And so we did what we could. There was obviously a shortage of PPE around the country, and so the role that we played even was to galvanize an army of our own associates to work with partners. In particular, it was North Memorial and Alina in our market to hand sew masks so that our providers had access to masks that they needed if they couldn't get the traditional medical supply of masks. We also had a similar effort in terms of protective shields so that we can make handmade products to support the providers, and that was a significant need at the start. The second was telehealth. Telehealth was not only a vehicle to assure that members could have access to services, but it was also a support function to the providers so that they could stay in touch with their patients in an alternative way, and that it would be a revenue stream. So we immediately harmonized reimbursement rates for telehealth so that a provider's reimbursement level for a telehealth visit was comparable to face-to-face or even for telephonic. So whether it was video or telephonic, to say, okay, now is not the time for the providers to worry about differential reimbursement rates for telehealth services when they very much cared about their patients and wanted to stay in touch. That had quite an impact on the quick evolution of care delivery in our market. There were, I would say pre-COVID, of all the visits that providers were generating in our market, only 1% were represented by telehealth visits. Now, for many of our systems, it was up to as much as 50%. One of them was 80% of all the services they were providing were telehealth driven. So it was an immediate safety net to some degree for the providers as well. And then beyond that, because of the sort of the impact of sort of the softening of elective procedures, we also wanted to find a way to accelerate payments to providers. Many of the providers that were already in value-based or partial capitation arrangements, our focus was to really accelerate those payments so that all the dollars were available now. So that in many respects, the providers were more like health plans, as I referenced earlier, that they didn't as much suffer the peaks and valleys because the reimbursement rates were value-based or population health-based, not fee-for-service or fee-for-procedure-based. And so we've done what we've been able to in terms of extending portions of our premiums to the providers so that they could be supported in this trying time. And I actually I have a slide here that I wanted to show. It's probably more complicated than your listeners want to see, but in essence, we've gone so far as to model where are the peaks and valleys within the environment that we're in right now. And in essence, to summarize what you see here, the purple line is what we would expect to see in terms of utilization related to COVID. The red line are services that are being deferred. And those would be services that we very much, that are essentially not happening during the midst of the COVID crisis for whatever reason. And the green line represents the return of the deferred cases. Now, some of them won't return, and that's represented in blue, a dark blue. But all told, the most important line to look at is the light blue line, which essentially shows we're seeing this period of unction. And even at the peak of COVID, we won't necessarily see utilization rise significantly above historic rates. But what we will see is utilization, as you look to the light blue line going out into the future, we will see a return of that deferred utilization later this year and into next. So the question that we focused on for providers is, what do we do in this period so that they're financially supported as we're waiting for the utilization to return later this year or next? And then finally, in terms of, how long will these things persist? And will any become permanent? Well, I've been advocating for value-based transformation or reinvention of our health system for a very long time. And the silver lining in this crisis, or frankly in these crises, is some of the changes that we're seeing now, frankly, should have been permanent a long time ago. And whether it's value-based reimbursement to providers, not fee-for-service, or a much greater increase in utilization, in telehealth services and utilization, or truly disparities in health inequities and the role that they play in worsening health of subpopulations in our communities, those are changes that, from my point of view, need to be permanent and should be perpetual.
Thank you. Actually, with that response, you've touched on some of my follow-up questions, which really were along the lines of the future, the post-COVID world. And you've touched on some of the things that you'll be doing. The question really is, in a post-COVID America, what do you see the healthcare delivery system looking like? And do you see specific challenges post-COVID for your own state and the market and populations you serve?
Yeah, these are all great questions. And each question, I'm sorry if I'm taking too long, have long answers.
Oh, that's great.
So out of my toolbox, let me kind of take another slide I put forward here, which is this one, that we can't go on. We couldn't go on before in terms of what care delivery looks like. And for those who can see this on their screens, in essence, is price inflation for all the services that we traditionally rely upon in our lives. And you'll notice that the highest rate of inflation is hospital services. And so what we were already facing was not sustainable. Hold on, it looks like we changed. So let me go back.
Is this it?
Someone else is changing it. There we go. All right, this is the slide I'm referencing, the price change. So the very top one, as you can see, represents hospital inflation. And so the rate that we were on, the environment that we were in, was not really sustainable anyway from a cost perspective, and I would argue not necessarily convenient. And also not very coordinated. So, I mean, I think that we were ripe for change long ago. And who would have thought that it would actually be a pandemic that would actually lead to the disruption that's been needed for us to rethink and reinvent care delivery. I was on a call earlier today about what my predictions are related to telehealth. But it also speaks to what we envision for reinvention. You know, to go back to the stats that I described earlier, if our old care model was 99% live and 1% telehealth, what does that then mean in terms of what the percentages will be in the future? Well, a couple things that I would say. One is, it's not just an either or. It's not the traditional care system and telehealth. The reality is there are going to be patients that need services beyond what telehealth can provide, and will require services at home or service in the community. And they may not want to come into the doctor's office as they did before or into the hospital. So I would predict that we will see the emergence and frankly, our care delivery division will play a significant role in Minnesota, hopefully, in this space. We will see a reemergence of home-based care. Hospital at home, urgent care at home, chronic care at home, and that house calls will return. Ideally, it will be our same provider partners that repurpose the way they work, perhaps less bricks and mortar and more mobile. But if we now think of a third dimension, then going back to my percentages, the old model is 99% facility, 1% telehealth, and 0% home-based care. In the call I had earlier with an organization, I suggested, what if the future world order is 50% facility-based, 30% telehealth, and 20% care at home? Which for me essentially describes what the future world order may look like. And let me click to another slide that I put in here to represent it. Folks may not be able to see it, but what if care looks like this? And I'll point to some things if you can't see it. First of all, in terms of telehealth on the screen, the television screen, you know, whether it's a navigator or a physician, what if caseworkers, support workers, care coordinators, care managers, and clinicians have the opportunity to interface more electronically? You know, we made the slide, by the way, at least way pre-COVID, because we envisioned a world where care delivery is reinvented. You know, what if you see the grocery bag on the chair in the corner, what if we had our version of, you know, HelloFresh or Blue Apron or, you know, grocery delivery, which many of us are getting today anyway, with a focus on, you know, food as medicine, where we have an opportunity, if folks are going to order, that we can actually focus on more healthy options. And on the desk in the forefront, if there's an Alexa equivalent to care when you don't necessarily want a telehealth visit. And then if you look out in the window, one of our care delivery divisions is called Livio, that this care in the home, the 20% that I described, is delivered by a mobile unit. And envision a world, especially in the near term, where that mobile unit is staffed by people who are tested for COVID every day, so that there is a safe environment for people to feel that they're receiving care in the home without being exposed to patients in other means. So I hope this gives you a snapshot of kind of how I'm thinking, how we're thinking about what care delivery may look like. I think this is long overdue. The only other thing that I would say in this regard that I hope is a way that care delivery will change is as it relates to social determinants of health, health inequities. We use the expression that an ounce of prevention is worth a pound of cure. And the ounce of prevention is not just clinical prevention, it's social prevention. It's all the inequities that exist in our communities that create differential outcomes. And equity is not that we provide the same care and services to everyone equally. Equity is when we expect that every part of our community has an equal right to high quality, high service, affordable health care, and frankly, to live a healthy life, which means that the future of healthcare delivery may very well be the intertwining of care and social. And so who says that organizations like ours can't get into, in a major way, the food insecurity, housing insecurity, loneliness, transportation barrier business, if we believe that truly investing in that ounce will result in better outcomes for our whole community. So those are the things that that we predict, I predict, will be the case in the future. And the biggest challenge for a plan like ours, I guess, is a challenge that exists everywhere. You know, frankly, what makes me excited about the time that we're in, purely just from a silver lining standpoint, is that I finally have an opportunity to change our industry. What keeps me up at night, and I think is probably our biggest challenge, is my fear that we will regress to where we were, that we don't go forward, and that we don't take this opportunity to change, and that we don't reinvent our industry. That's my greatest fear, and I think that's probably our biggest challenge.
Thank you. A lot of food for thought here. Along those lines, and this will tee up some detailed questions a little later on payment integrity, but at the strategic level, the things you're defining now and talking about, and it is becoming more and more of a topic, obviously. What do you see as the long-term financial impact? We know the short-term, we're seeing some of that now, but how are you seeing the activities that will continue affect the financials of healthcare?
You know, the first thing that I would say is I think we're going to see, first, I would hope that what we will see is a bending of the curve so that healthcare is more sustainable and affordable. So before this even started, we had a problem. And I'll start in Minnesota. In Minnesota, from 2018 to 2019, so essentially last year, we saw a 9% increase in the total cost of care year over year, which is triple the national average, and frankly not sustainable versus, and so we can't keep on that trajectory. Healthcare was unaffordable before we started. There isn't, I've been saying, I think, for decades that there isn't going to be any more money in healthcare, and somehow we find a way to make more money in healthcare. It has to stop. And so my first hope is that the impact of COVID is that we can find a way, either through reinvention or other needs, to really suppress the inflation, because it's not sustainable. That would be my first thought. My second is I think we're going to see a redistribution. I think we'll all be redefined by this. Ideally, we all should change. Should hospitals be as even we described pre-COVID, should they, to assure that they have the capacity in the midst of a crisis like this, should their capacity be reserved for ER, OR, and ICU? And the services that don't need to really be facility-centric can find another alternative, which means revenues and costs may shift. Do we create these mobile and virtual care delivery models, which means resources will shift into the creation of new organizations, or maybe the reinvention of care delivery organizations or systems to take on a very different model? So I hope that this doesn't drive up the cost of healthcare. I don't necessarily think it will drive down the cost of healthcare. I think it will predominantly lead to a redistribution of healthcare dollars.
Okay, interesting. Thank you. So with that, what I wanted to do now, and it is certainly the component of the financial question, specifically to payment integrity, all plans, including yours, I'm sure, have rather robust payment integrity models that they work with and are traveling along a continuum of payment integrity. But with what's happened now with the crisis, a lot of questions have come into play around payment integrity programs. In the short run, what activities has your organization modified or extended? For example, reducing pre-authorization rules as an example, things of that type. Yeah. That would be of interest, I'm sure, to this audience.
Yeah, I mean, I think one of the immediate things that we did was really, I have long been I guess let's put it this way, I'm an equal opportunity critic of a lot of parts of the healthcare industry, and I've been in many parts of the system. So I'm frankly not a real big fan of prior authorization. When I was at Anthem, I looked to change that, and I'm looking to change that now. I think it's easier to change that when you actually have closer partnerships between payer and provider, and it's more value-based. But so I've never really been a big fan of rules, but they're necessary. In the prior authorization has been the mechanism that we've assured that care delivery is consistent with evidence-based guidelines. But in the midst of a crisis, that doesn't make a lot of sense. And so as we've relaxed prior authorization rules in the midst of crisis, especially as it relates to COVID-related activities, let's see, we've updated payment codes, obviously to tie them to COVID-related services, especially as we waive cost sharing. That's kind of been an essential change that we've made. We've wanted to reduce the bureaucratic impact wherever we could on providers. deferring medical record requests, the things that would be considered normal course of business that just seem a bit less important in the near term. Allowing recovery beyond standard look-back periods is probably another that's been a change in the near term. And then I guess, this isn't necessarily an action that we've taken yet, but one that we are focusing on that we need to begin to think about, especially with the evolution of care delivery and the shift more toward telehealth services, is where will we see new fraud, waste, and abuse that we hadn't necessarily expected and thought of, that we now have to be cognizant of, because in crisis there's opportunity, and opportunities could be good behaviors and bad behaviors. So we have to really think about where we create exposure for consumers and payers, not just us, self-insured payers as well, that we have to be hyper-cognizant of. I don't know if that answers your question, but those are some of the things that we've been thinking about.
No, and specifically, and you referenced telehealth, and that's a big one. Are you seeing, certainly now it's being treated on parity with regular visits. Do you envision the future to be the same, or do you see some of this pulling back or potentially finding a new normal for all of this? So that's a follow-up question on telehealth itself. Another question to look at is, and some plans have been making advances to providers to keep them afloat. Is there going to be, they're in the form of loans or prepayments to support cash flow? Do you see that as becoming a potential problem in the future in terms of reconciliation, or is that just sort of water under the bridge and we'll deal with the future when it comes?
Yeah, let me see if I can take each, and I'm getting older, so if I forget the second one while I'm answering the first, just remind me what it is. Okay. But in terms of the first, we want there to be more telehealth, not less. And so if reimbursement mechanisms have been the barrier to advancing telehealth, then we need to fix reimbursement for telehealth. That said, my preferred approach in financial relationships and contractual relationships with providers is joint accountability, as I put it. So where we are both accountable not just for quality outcomes but for cost. And so gain share and risk share arrangements, whether it's primary care capitation, if we have a different type of relationships with providers where we're paying PM, then we don't have to worry about whether we should harmonize reimbursement rates for face-to-face or telehealth. That physician's getting the same amount of money to care for a population, and it's their choice about what's best for the patient, whether it's telephonic or virtual or whether it's face-to-face. And so I think what I'd rather do is we move to a more contemporary reimbursement model overall, so that we don't stay within a volume-based system, which is fraught with all kinds of issues. Frankly, no one should be profiting off of a crisis, from my point of view. Health plans should not, care delivery organizations should not. I think one of the concerns that I have, and frankly, I've heard from family members and friends that have had outreach about telehealth visits when it hasn't really been needed or warranted, or the telehealth visit needs to be coupled with something done face-to-face, which isn't done. So why have the telehealth visit if you can't do what's really needed, blood test or what have you? So we get away from all of that, I think, when we pivot to a more value-based model. Okay, see, and as I promised, I forgot the second part. So what's the second part?
The second part was, and I'll avoid compound questions, the second part was related to loans and advances,
right.
prepayments that organizations have made and what the future for that is, and recovery in particular.
Yeah, I mean, we haven't shifted to, reimbursing systems to the exact run rate that they were being paid previously. Our advance payments sort of don't amount to that type of scale. So I don't think we worry about reconciliation. And frankly, we'd very much like to, as I've stressed several times, we really want to advance to come up to these value-based models more significantly. And so reconciliation becomes a whole lot easier if we essentially say we're going to have a shadow budget. It's going to be a PMPM reimbursement, and we're going to look at, if there's significant favorability, we're going to share in the favorability. If there's significant loss, we're going to share in the loss. It makes it a whole lot different and a whole lot easier to kind of do some of the reconciliation. But I don't envision that will be a material problem for us.
Okay. And somewhat related to that, and it may not affect you depending on your model, there has been some confusion, some would argue a lot of confusion around the no-cost coverage of COVID-related claims and what patients, providers, and payers think that means, and the potential abrasion, the misunderstandings of that could lead to in the future.
Well, I mean, I think that, first of all, I probably should have mentioned this earlier. When you asked the question about how long do things continue, I think that sort of thing continues, that, as long as COVID is around, at least in sort of high volume instances, as I think many markets are in right now, that cost sharing position really should be preserved. I think as it relates to fraud, waste, and abuse, and we've kind of gotten questions about this, is if someone goes in with COVID symptoms face-to-face with a physician and has a COVID test, or he is even being treated for COVID, but then has a bunch of other services that are entirely unrelated to COVID. So let's take it to the furthest extreme that I'm going to bring you in to do a hip replacement procedure, but I'll do a COVID test at the same time, which means that all cost sharing should be waived. That's the sort of thing that I think we have to find a way to avoid. That doesn't make a lot of sense. So where clarity is needed, I think we need to bring clarity. But from our point of view, anything that's related or interrelated, COVID test concurrent with a flu test, or anything that's related to the symptomatology that you would expect. And the symptomatology with COVID is pretty broad, as you know. I mean, it can affect many systems, body systems. And so treatment and testing related to those that clearly could be interconnected should be covered, and things that clearly are irrelevant should not.
Excellent. Okay, thank you, Dr. Samitt. We are, I understand, getting a lot of questions from our audience, so I am going to try to get some of those to you. Let me see if I can use this technology to read these questions. So a question that has come up. Minnesota is known as a leader among states for implementing administration simplification through EDI, i.e. electronic transactions. Do you think that, that's cut off. Do you think that in the midst of the pandemic, the question is partially cut off.
I can see I can see the
You
question.
can see them.
Yeah.
Okay.
Yeah, I can see the question. It says, do you think that helped your state in managing in the midst of a pandemic?
Yeah.
it did help. I think it does help. You know, I think it's an example of sort of how the industry really has needed to evolve, and in instances where we are more contemporary and more progressive than other states, and I think that very much has helped us in the midst of the pandemic. You know, I'm relatively new to Minnesota, but I'm singing Minnesota's praises because I think there's a lot that Minnesota has done to really help manage in the midst of the pandemic. You know, Minnesotans rally to solve problems, and we've seen a lot of alignment amongst the payers, a lot of alignment amongst the providers across payer and provider. But Minnesota has often been the leader in several things as it relates to healthcare transformation, including administrative simplification through EDI. So I think that really has contributed to it.
Excellent, thank you. Next question, and this seems to be focused around telehealth. Do you have any rules around telehealth? Do you have the infrastructure to help monitor or control the spend due to the ease of access?
We do have rules as it relates to telehealth. So now, in many respects, we've relaxed a bunch of those rules in the midst of the pandemic. And one of the things that we have to begin to think about is to what degree do those rule relaxations remain permanent, or to what degree are we concerned about misuse or overuse, and that we need to go back to prior rules or to strengthen rules. Do we have the infrastructure? I don't know if any of us have enough of an infrastructure to really understand appropriateness. You know, I don't think, and it's all across the board. I mean, ideally, I would love to see better decision support tools, better shared decision-making tools, so that patients know what to ask for, and frankly, better fraud, waste, and abuse tools, so that we understand where, you know, bad behavior, bad opportunities are being taken advantage of. So I don't think our infrastructure is as good as it could be, and, you know, I think we should all be amenable to better tools and better alternatives.
Thank you. Also related to telehealth, apparently an interesting topic for a lot of folks these days, is expanding, if you can expand on the future of telehealth and its impact on care fragmentation. You suggest, and the questioner agrees, that local practice-based telehealth is positive, while national telehealth platforms create a new set of problems. How do we align what we want with care with who delivers it?
Yeah, I think there, again, to repeat myself, you know, in the midst of crisis, there's opportunity, and I think there are many organizations that see that opportunity, especially as it relates to telehealth. So I would envision we're going to see at least 3 different groups that will compete for telehealth. One are the existing national telehealth organizations that we all know very well. And remember that they're essentially providing 1% or less than 1% of all healthcare services. The second group that I envision that we will see is our new entrants into the telehealth space that can very well come from existing well-branded care delivery systems. So if I'm organization X and I have a good reputation for high-quality care delivery, well, you know, maybe I can disintermediate community-based care delivery by getting more boldly into the telehealth space. So I think we're going to see a greater disruption and entrance from new players. And then the third is what we're talking about here, which is local care delivery, which requires an ongoing embracing of care delivery by the existing delivery systems in our markets. I still would like to see the third as my preference. for the reasons that have been asked, that, you know, it likely leads to an inevitability of fragmentation of care and services if we've got care being provided in an uncoordinated way. Now, if we could make advances in sort of unification of electronic health records, or, you know, clinical claims and community data is viewed as a common good, and it belongs to the patient and the member, not to the organizations that generate a unit of data. If that existed, then and anyone who delivers care could have access to it, that would change the ballgame, but that's not the reality today. The other thing is, you know, given our view that we want to move more toward population health partnerships and joint accountability, that's hard to do if care is significantly fragmented. It's easy directly with local care systems and with physicians.
Excellent. Thank you. Another question, and let me see if I'm reading it correctly here, seems to be that there are competing goals between CFOs who might want to preserve current fee-for-service reimbursement models with need across the U.S. for moving to value-based, not just like in Minnesota that's more progressive. So I believe the question is about your thoughts on your progressive type of programs moving across the U.S. more, and potentially resistance to that because people are comfortable with the current models as they exist.
Yeah, this is a really hard one because you know, circumstances vary across the nation in terms of why value transformation isn't happening. And I think, you know, I see it, I hear it every day, I hear it every week, that if you talk to some, I've had some outreach from provider systems around the country that have said, what can you do to help my local health plans pay attention and be willing to partner with us in value-based arrangements? So in essence, talking to providers who are saying the reason value isn't happening is because the payers are not willing. And likewise, in entirely different markets, you see very willing payers, but the providers much prefer volume-based care and are doing very well, thank you, in the old way of delivering care. And so there isn't one answer to help transform the whole nation, given that the various players are in various places. My best hope, as you can tell from this call, I'm not shy about sharing opinions, and so one of the things that I feel like my role is nationally is to be an evangelist for transformation and reinvention. So I'm certainly not going to be shy about making my opinions known, but also I want us to be a model. I mean, if we can make a transformative reinvented care model work in Minnesota, and we can demonstrably show employers and patients and members and the community and providers that sort of the water's warmer in a value-based world than where we're coming from, and we can, you know, deliver on the quadruple aim and prove that it's achievable, better quality, better service, lower cost than the clinicians. If we can do that here, then my hope is that others will try to do that in their own local markets.
Great. Thank you. Another interesting question here to you, Dr. Samitt. Clearly there is, and it's been in the news, deferred claims in this time frame by patients. And when and if those return, those needs, will they, in your opinion, now be more complex and therefore more expensive because the patient's health issues have worsened because of the deferment? And do you see that as a significant factor or not a major impact in the future?
I mean, immediately I would say yes. I think that yes, in part. It very much depends on the clinical condition. And so if there are those with chronic diseases or frankly oncologic diagnoses or cardiac diagnoses that are not receiving care, which frankly don't tend to be the elective procedures that are being deferred, but it's really more chronic care management that gets deferred. If folks need chronic care management today, they need to receive that care today because deferral of that care could lead to worsening outcomes and obviously higher costs later on. So I think that is the case. But things that are elective, truly elective, that are being deferred, well, I'll give you an example, cataract surgery or even joint replacement procedures, they're not necessarily going to get a whole lot worse if they wait 6 months or if they wait a year versus the other things that I've mentioned. So I think it depends. Some will come back with a fury. Some will be exactly the same. Frankly, some will just never happen because there's some indication to suggest, given the drop in utilization, that perhaps we were providing a bunch of care to people that wasn't making them any healthier, that were low value anyway and really unnecessary and unwarranted. That may never come back, and maybe it never should.
Okay. I think we're probably going to go to our last question. And this is an interesting one, tying to your comments about some of the innovative programs you have around delivering care in the home and in the future. So the question is, what role is wearable medical devices having to monitor patients remotely to reduce burdens on hospitals, allowing patients to leave earlier or to remain at home and be monitored without being admitted to the hospital?
I think it's going to be huge. I would envision as part of care delivery, and I mostly, talked about it as virtual health or home visits for chronic care management. But we may very well see a surge and emergence of higher percentages of hospital at home. And I think what we will find is that there may be several diagnoses where it's perfectly safe to have hospital at home as long as there's better home-related monitoring. And the same may very well be true, frankly, of post-acute care. So it's either hospitals at home or post-acute care at home, that we may find that, as long as we can track movement or vital signs or, other clinical metrics or social metrics that could tell us when someone would get into trouble, we may not need to be so paternalistic and expect that they need to be in a facility or be in a hospital to have that done. So I think we're going to see monitoring as a significant element of care delivery reinvented.
Thank you. Okay. I think that there have been many more questions, and it's tough to sort through them all on something like this. But I think we're at the end of our program. So, again, I wanted to thank you, Dr. Samitt, for your insights and for sharing your insights with this audience. I certainly learned a lot, and I hope our audience did as well. So, again, thank you for your participation in this.
My pleasure. Thank you for having me. And most importantly, I hope everyone is healthy and safe.
Thank you. I do as well. Kathleen, do you want to just offer up the concluding component of this?
Yes, thank you, Soren. I want to thank our speakers once again for an excellent presentation, and I also would like to thank our sponsor, CAQH, for making today's program possible. On the screen is contact information for Soren. Please feel free to connect with him on LinkedIn or send an email to the address displayed. Finally, thank you to you and our audience for participating today. We hope you'll join us in the future for another Health Leaders webinar. This concludes today's presentation.
Thank you.